You have been to 3 doctors this year. 3. One for the palpitations that started waking you up at 2 in the morning, heart just racing for no reason while the rest of the house slept. One for the pain in your hands that showed up one January and never really left. And one, and I want you to hear this, one for the recurrent UTIs that you never had a single time in your life before you turned 50. And every single time you left with a shrug, maybe a referral, and some version of, "These things happen at your age." Look, I have been doing this for 30 years, and I need to tell you something that nobody in any of those offices told you. What is happening to you is not 7 different problems. It is one. And the fact that nobody connected those dots for you is not an accident. It is a curriculum failure. Fewer than 7% of OB/GYN residency programs in this country include dedicated menopause training. 1 in 5 women is dismissed at the office when she brings these symptoms in. 75% of women going through this transition are left entirely untreated. Those are not my numbers. Those are published, peer-reviewed, sitting in journals that the people writing your referrals read. And still, somehow, nobody said it plainly to you. Here is what they also did not tell you. Before menopause, your estradiol, the primary estrogen your body runs on, cycled somewhere between 50 and 500 picograms per milliliter, depending on where you were in your cycle. After menopause, that number drops to somewhere between 10 and 20. That is a reduction of up to 95%. And estrogen receptors are not only in your ovaries. They are distributed across more than 400 tissues in your body: your heart, your joints, your bladder, your brain, your skin, your gut lining. Every one of those tissues registered that withdrawal, just not all at once, just not in ways that look connected on a chart. So you ended up in 5 different waiting rooms, holding 5 different referrals, quietly wondering if something was seriously wrong with you, or if this was just, somehow, who you were now. It was never who you were. And what I am going to show you in the next few minutes is going to change every conversation you have with every doctor from this point forward. Stay with me. Because the symptom that frightens most women on this list, the one almost no physician is trained to recognize as hormonal, we have not gotten to that one yet. Your mother did not have a word for what happened to her, not a clinical one. She had words like change, or more likely she had silence. She went through it with a dignity that looked, from the outside, a lot like nothing was happening at all. And if you asked her, if she was even someone you could ask, she probably said something like, "You just push through it," or "That's life," or she simply changed the subject. That is not strength, by the way. That is what it looks like when an entire generation of women was never given the language, never given the biology, never given a single sentence that explained what their own bodies were doing. My mother was the same, and I watched her. I watched her push through things I now understand were estrogen withdrawal symptoms affecting her cardiovascular system, her cognition, her sleep. And nobody, including me at the time, had the vocabulary to name what I was watching. Then 2002 happened. And if you are over 50, you need to understand what 2002 actually did to you, not in the way it was explained then, but in the way we understand it now. The Women's Health Initiative study came out that year, and before anyone had fully read the methods, before anyone had separated synthetic progestin from bioidentical progesterone, before anyone had looked at the age of the participants, most were in their 60s and 70s, well past the therapeutic window. The headlines ran, "HRT causes cancer. HRT kills women." Prescriptions dropped 80% within 2 years. And the generation of physicians who trained in the decade that followed, which includes many of the doctors writing your referrals right now, trained inside that panic. They inherited not just the caution, but the avoidance. This was never about evidence. It was about fear wearing the clothes of evidence. And here is the part that genuinely makes me pause, even now. The medical training system had a window, a full 2 decades after the WHI, to correct course, to go back to the data, to do what medicine is supposed to do, which is follow where the evidence actually leads. Instead, a survey published in the journal Menopause, not a fringe publication, the clinical journal of record, found that the average graduating OB/GYN had received less than 1 hour of dedicated menopause instruction across their entire residency. Less than 1 hour. For a hormonal transition that will affect every single female patient they will see over 50 for the rest of their career. So when your doctor shrugs, and I want you to hear me on this, it is almost never because your symptoms are unimportant. It is because she may be working with a 40-year-old framework in a body that needed something different entirely. There is something deeper here about how that framework keeps failing in one very specific area of the body. And I am going to get to that. So let's name what actually happened here. And I mean name it specifically, because the system failed women is something people say and then move past without ever looking at the architecture. What actually happened is this. The specialty structure of American medicine was built to treat organs, not events. When your estrogen dropped, the cardiologist who saw your palpitations had no training linking them to hormonal withdrawal. The rheumatologist treating your joint pain had no reason by training to ask when your last period was. The urologist treating your bladder infections was handed a protocol that began with culture and sensitivity, not endocrinology. And in the space that clinical medicine vacated, the supplement industry moved in. The global market for menopause-related supplements now exceeds $6 billion annually. That number is not medicine. That is profit built on a question nobody answered. And here is what makes this genuinely difficult to sit with. There are currently fewer than 1,200 certified menopause specialists in the United States. 1,200 for more than 50 million women living in perimenopause or postmenopause right now. That is a ratio that makes the training gap not just a curriculum oversight, it makes it a structural guarantee of continued silence. The women paying the price are not a statistical category. They are the women who spent 3 years collecting referrals for a single systemic event that nobody connected. The women whose quiet self-doubt, which is exactly what untreated neurochemical withdrawal produces, was documented in a chart as anxiety and sent home. And before we go further, I need to tell you, there is one specific tissue in your body where estrogen withdrawal produced the most invisible damage, the kind where the consequences take 15 years to show up on a scan. We have not gotten there yet. Here is what nobody names for you. When estrogen starts withdrawing, not all at once, but in that uneven perimenopausal pattern, your hypothalamic pituitary adrenal axis does not quietly adjust. It dysregulates. Cortisol, your stress response hormone, starts running chronically higher. Not because your life got harder, because the signal estrogen was providing, the one that told your HPA axis to stand down, has gone quiet. Your nervous system reads the withdrawal as danger. Your doctor calls it anxiety, writes it in the chart. Meanwhile, cortisol running at that elevation does something clinically measurable. It drives fat storage directly toward the abdomen. That is why a woman can do everything right: the same food, the same movement, the same discipline she has had for 20 years, and still watch her midsection change. Not willpower, not lifestyle. A hormonal architecture shift nobody connected for her. And that is only the first layer. Progesterone was doing something inside the brain that matters just as much. And what it stops doing when it falls is the part we have not named yet. What almost never gets tested, and I need you to hear this, is testosterone. Women produce testosterone throughout their lives. By natural menopause, free testosterone has fallen to roughly half of peak mid-20s production. Half. That loss carries real consequences: blunted cognition, flattened motivation, accelerated muscle loss, and something harder to quantify: the loss of feeling present inside your own body. When it goes unmeasured, women are told their word loss is anxiety. Their vaginal burning and dryness, a progressive condition affecting more than half of postmenopausal women, one that does not self-resolve, is just aging. None of those labels locate the mechanism. The urogenital tract carries among the highest estrogen receptor concentrations in the body. When withdrawal meets that density, the tissue thins and local immunity drops. Treatable, not inevitable. But the physician across the desk was often never trained to say so. And when estrogen, progesterone, and testosterone all fall in the same body at the same time, the result is not 3 separate losses. It is a cascade. And what that cascade does to one specific tissue, that is the part we are almost ready to name. In 30 years of practice, I have seen this exact pattern thousands of times. A woman arrives holding referrals and no answer that actually holds. But I want to tell you something that is not clinical. I went through this myself. I was 53. I remember standing at my kitchen counter, early, still dark outside, the house completely quiet, and I could not find the word for what I was holding in my hand. A mug. I am a physician. I have said that word thousands of times in my life, and it was just gone. For a moment that lasted longer than it should have, what I felt was not frustration. It was a specific, quiet fear, the kind a doctor feels when she recognizes something in her own body she does not want to name. It took me months to understand. It was not neurological. It was a brain running on chemistry that had been systematically dismantled, and nobody had thought to recalibrate it. The mechanism behind that exact symptom the one that frightens women most because they are terrified it means something else entirely, is where we are going next. Let me explain what is actually happening in your body, not as a list of symptoms, but as a sequence of events that make each other worse. Start with your heart. Estrogen maintains the elasticity of your vascular walls and regulates something called thermoregulatory tone, the calibration that keeps your blood vessels responsive to temperature changes. When estrogen falls, that calibration loses its anchor. Studies comparing perimenopausal women to premenopausal controls have documented a 2 to 4 times increase in reported palpitations. 2 to 4 times. Not a cardiac anomaly, not caffeine. Vascular tone losing the signal that kept it steady. A cardiologist handed that symptom runs an EKG, finds nothing structural, and writes anxiety in the chart. The mechanism never gets named. And the mechanism is what changes everything. Because the same withdrawal is simultaneously happening in your joints. And that part, if anything, is even less discussed. Your joints have estrogen receptors too. Estrogen directly suppresses inflammatory cytokines, specifically IL-1 beta and TNF-alpha in synovial tissue, which is the membrane lining the inside of every joint. While estrogen was present, it was actively down-regulating inflammation at that cellular level. When estrogen fell, the downregulation stopped. That stiffness in the morning, the deep ache in your fingers, the pain that worsens in the cold and loosens when you move, that is measurable synovial inflammation, not structural injury, not simple wear and tear. Clinically, the pattern has a name: estrogen withdrawal arthralgia. Most physicians never say that name to their patients. The referral comes in, the joint gets evaluated in isolation, and nobody steps back to ask what else changed in this woman's body in that same 12-month window. That is not aging. That is a hormone shift nobody explained to you. And the bladder is doing the exact same thing. And that one tends to surprise women the most. I had a patient, I will call her Patricia, who came in after 4 rounds of antibiotics in 8 months. She sat across from me and said, and I am quoting her as closely as I can remember, "I feel like my own body is attacking me. I take care of myself. I do everything right. And I keep getting these infections." She was bewildered in a way that was completely warranted. What she did not know, what nobody had told her, is that the bladder, the urethra, and the pelvic floor carry among the highest concentrations of estrogen receptors in the body. When estrogen withdraws, the urogenital epithelium thins. The tissue itself becomes less resilient, less capable of sustaining local immune defense. Recurrent UTIs increase 3 to 4 times in postmenopausal women compared to those same women's earlier adult years. When I walked Patricia through the mechanism, explained that this was a tissue change driven by hormonal withdrawal, not a hygiene failure, not anything about her habits or her anatomy, she went quiet for a long moment. Then she said, "So no one was actually treating the real problem." She was right. No one was. Now the brain, and this is the part that frightens women most, because the symptom feels like something far worse. Estrogen modulates serotonin, dopamine, and acetylcholine. Those are three of the primary neurotransmitters governing mood, memory retrieval, and the speed of cognitive processing. PET imaging studies have captured measurable shifts in brain glucose metabolism during perimenopause. The brain's energy use pattern changes in ways that are visible on a scan. That is not a feeling, that is physiology. Progesterone was doing something here as well. It acts on GABA receptors, the receptors responsible for calm and sleep depth. By the time progesterone approaches near zero post-menopause, sleep architecture fragments. Women stop reaching deep, restorative sleep stages. They wake at 3 in the morning, not from stress, not from a racing mind, but from a GABA system that lost its primary modulator. And the cognitive erosion that follows chronic sleep disruption compounds the neurochemical shift that was already underway. What that compounding produces across years, that is exactly where we are going next. Here is the turning point. The conventional message is eat less, exercise more, manage your stress. For most of your adult life, that worked because it operated inside a hormonal environment that held insulin sensitivity stable, regulated fat distribution, and kept inflammation from accelerating. Post-menopause, that environment is gone. Insulin resistance measurably accelerates. Skin collagen declines roughly 30% in the first 5 years following menopause. The strategies that worked before did not stop working because she stopped trying. They stopped working because the hormonal infrastructure they depended on quietly disappeared. She did everything right. Same food, same movement, same discipline. Then, somewhere between 50 and 53, it stopped responding. The weight shifted, the energy dulled, the sleep broke apart. And without anyone offering a different explanation, she blamed herself. Quietly, methodically. Concluded she was not trying hard enough, not disciplined enough. That conclusion was physiologically wrong. The strategies failed because the biological infrastructure they depended on had been dismantled, without a single person explaining what was actually happening. You are not crazy. You are not alone. The self-doubt you have been carrying is not a personality trait. It is a documented symptom of the exact biochemical changes we have been naming. Progesterone near zero means GABA dysregulation. GABA dysregulation means sleep that never fully restores, impaired mood regulation, heightened cortisol reactivity, and a persistent sense that something is wrong with you specifically. The quiet erosion of confidence, the wondering if this is simply who you are now, that is neurochemistry, not weakness, not failure. The 10 to 30-year picture is where this silence carries its full weight. 1 in 2 women over 50 will experience an osteoporotic fracture. Hip fractures in older women carry a first-year mortality of roughly 20%. That is bone architecture that was never supported through the remodeling window when support was still possible. Cardiovascular disease is the #1 cause of death in women over 60, not breast cancer. The heart has been paying for the silence for years, quietly, without a symptom to announce it. Longitudinal cohort data shows associations between prolonged estrogen deprivation and modestly elevated dementia risk, real, published, and worth knowing before 65, not after. The part I need you to sit with is right now. Approximately 70% of women in this transition report anxiety symptoms, not a personality tendency, a neurochemical shift inside a brain that lost the architecture keeping its emotional regulation calibrated. Depression rates double in perimenopause. And without anyone explaining that mechanism, what the woman experiences is shame. The quiet, accumulated shame of someone who cannot understand why she is struggling when nothing in her circumstances explains it. She is alone with a folder of referrals and a growing conviction that the problem is her. That conviction is not insight. It is a documented symptom of exactly what we have been naming. What has changed in this room is your framework for understanding. For years, you were inside a medical structure that handed you fragments when you needed a whole picture. You tried the supplements. You adjusted your food, your sleep, your stress levels. You looked inward for an explanation the system should have given you outward. You are not failing. You were never told the truth about what was happening. The strategies stopped working because they were built for a hormonal environment your body no longer had, and not one person thought to explain that distinction to you. The direction from here is a specific, informed conversation with someone who was actually trained to see the whole pattern, a NAMS-certified menopause specialist. The North American Menopause Society maintains a public database of them. What you are walking out of this room with is not a protocol. It is language, the clinical language for a systemic event that was always one thing, never 7 separate failures. You are not a woman with a body that has been betraying her. You are a woman who finally understands exactly what her body has been trying to tell her. What we haven't named yet is the window. Today covered the origin of fragmentation, but there's a second layer. What happens between 50 and 65 while biology still responds? This is the remodeling window. What closes, what stays open longer than expected, and how to find someone who knows how to act within it. This was never just about symptoms. It was about timing. And once timing is yours, everything changes. Take care. I'll see you next time.